Okay, we're going to talk about ultrasound features of solid breast masses as prognostic biomarkers. And I view this as part of precision or personalized medicine as opposed to the one-size-fits-all. There are several types of imaging biomarkers, including diagnostic, predictive, prognostic, and monitoring. So in this talk, we're going to concentrate on prognostic biomarkers. A lot of what I'm going to mention here comes from the article by Jessica Leung and Olena Weaver on biomarkers, AGR 2018. Now, all the way back in the early 1990s, we noticed that there was a difference in sound transmission between grade 3 and grade 1 tumors, and the grade 1 tumors tended to shadow, grade 3 tumors tend to have enhanced through transmission, and grade 2 could be somewhere in between. And this was our data from way back then, showing that we had a 2.37 times larger chance of being grade 3 if there was enhanced through transmission, and a 0.4 chance of it being grade 3 if there was shadowing. And our data today confirms that and is even better. We also came up with differential diagnoses for altered sound transmission way back then, that acoustic shouting went with IDC grade 1 or 2, or ILC grade 1 or 2, or tubular carcinoma, whereas enhanced sound transmission usually went with grade 3 IDC, especially triple negative, but some mucinous carcinomas, some carcinoma in situ, some medullary carcinomas, or invasive papillary carcinomas. We do know of some other breast imaging biomarkers, and so we'll just mention them now. Mammography, we know that triple negatives tend to be round, circumscribed, or indistinct. What appears to be round on the mammogram is more often plump oval on ultrasound. We know that ER positive and luminal molecular subtypes tend to be spiculated, and we know that segmentally distributed fine, linear, and branching microcalcifications are more likely to occur in HER2. On MR, we know that ring enhancement tends to go with triple negative, and cluster ring enhancement tends to go with grade 3 DCIS/DAB, and we'll talk more about that in the non-mass talk. And then in mammography and MR, that multifocality is more common in HER2 and luminal B tumors, and that luminal A and triple negatives are mostly often unifocal, and that large bulky lymph nodes tend to favor HER2 or luminal B cancers. Now, more recent literature shows us that luminal A cancers tend to be low histologic grade, have spiculated margins and posterior acoustic attenuation. And the triple negative cancers tend to be higher grade, circumscribed or microlobulated margins, and have absence of a thick echogenic rim with posterior enhancement. And those things, to some extent, are confirming what we knew way back in the 1990s. Now, we have a larger database of 603 invasive malignant breast cancers for which I had ER, PR, HER2, Ki67, and molecular subtypes, and an ultrasound scoring system that we could analyze for more up-to-date and more extensive large database data for molecular subtypes for prognostic biomarkers. And so basically, molecular subtypes are best determined by genetic assays, but we've come up with surrogate receptor biomarkers where we can use ER status, PR status, HER2 receptor status, and Ki67 to come up with surrogate molecular subtypes. And so if we can find correlations with any of these individual receptor data or combinations thereof, then we can say that yes, we've got prognostic biomarkers that we can assess with ultrasound. So sound transmission, which is what I noticed way back in 1990, remains an extremely powerful prognostic biomarker. It correlates with ER status with p-values at 10 to the minus 16, PR status 10 to the minus 15, even ER positive, PR positive versus ER positive, PR negative with a p-value of 0.003. And a little weaker correlation with HER2, 0.008, and with continuous Ki67, and even the lymph node status. So you can see that I've color-coded these. If I'm showing it in green, the p-value is less than 0.001. whereas if it's aqua, it's better than the typically used 0.05, but not better than 0.001. But you can see all of these are green colored or aqua colored, meaning they're all significant. Now, if we look at specific things, sound transmission versus ER status, if I looked at enhanced sound transmission, it increases the likelihood of the lesion being ER negative by 3.8-fold. And if there's shadowing, partial or complete, it increases the chances of it being ER positive by 3.6-fold. So on the left is a shadowing lesion that would typically be your ER positive. The right is an enhanced lesion that would typically be ER negative. Now, when we look at PR status, it's very similar. PR negative status is 3.8 times more likely if there's enhancement, and PR positive is 2.3 times more likely if there's shadowing. And again, we can see that the enhancement on the left is more likely going to be PR negative, and the weak shadowing on the right is more likely PR positive. We can even see a difference in ER positive, PR positive versus ER positive, PR negative. Again, enhancement makes ER positive, PR negative 2.7 times more likely than ER positive, PR positive. And shadowing makes ER positive, PR positive 1.4 times more likely than ER positive, PR negative. So even these mixtures of ER and PR status can affect sound transmission. Now, what's interesting is partial enhanced through transmission was seen particularly with HER2. It could be partial normal, partial enhanced, or partial enhanced, partially shadowing. But partial enhancement made HER2 positivity 2 times more likely. And we can see that 17.7 versus 8.8%. So it's not a majority, but it's a significant relationship there. So in our scoring system for sound transmission, 0 is enhanced sound transmission, 1 is normal, 2 is partially enhanced, partially normal, 3 is partially enhanced, partially shadowing, 4 is partial shadowing, and 5 is strong shadowing. And you can see that scores of 2 and 3 tend to go with HER2. Now, Ki-67, we had a tremendous number of correlations. And really the only thing that didn't correlate was the internal echo pattern score. But the sound transmission score, which is posterior feature score in BI-RADS, external margin, boundary score, peripheral zone, sums of scores, everything showed a lot of significance. Again, green means better than 0.001, and aqua means better than 0.05, but not better than 0.01. But you can see there are really only 2 of these features that didn't really correlate with Ki-67. So we've got enhanced through transmission here. That's going to tend to go with a high Ki-67 on the left, and on the right we've got shadowing, which is going to tend to go with a low Ki-67. Now when we look at lymph node status, again, sound transmission has some correlation with lymph node status. And it's not exactly what you think in general. Enhanced sound transmission goes with grade 3 and triple negative. But we know that triple negatives are less likely to go to lymph nodes. And when we actually look at it, we can see that partial or complete enhancement actually has a higher percentage of negative nodes than complete shadowing. And that seems paradoxical because shadowing is generally a better prognostic biomarker. But when we think about it, we know that the cell junctions of lymphangiogenic vessels, neolymphatic vessels, are abnormally wide compared to normal lymphatics, and therefore metastasis is more likely to occur with lymphangiogenosis. And we know that VEGF-D corresponds to lymphangiogenesis, and that the degree of shadowing is proportional to ER. And if you have increased ER, you have increased VEGF-D and increased lymphangiogenesis and increased lymph node mets. So it actually all does make sense, even though it originally seemed to be paradoxic. Now, way back in 1995, we mentioned that sound transmission correlated with histologic grade. And we can still see that that's true. We can distinguish grade 3 from other grades with a p-value of less than 10 to minus 17. We can tell grade 2 from other grades with p-value of 0.000011. And grade 1 from all other grades with p-value of 0.00196. So when we look at enhancement versus grade, we can see that enhanced sound transmission makes grade 3 3.5 times more likely than grade 1. And when they're shadowing, it makes grade 1 2.9 times more likely than grade 3. So this is what we showed way back in the 1990s, but even better. Still true today. Now, when we look at the scores, the higher the score, the more likely is and more extensive the shadowing. So we can see that grade 1 and grade 2 have higher scores than grade 3 because they tend to be associated with shadowing, whereas grade 3 tends not to be. So grade 3 stands out in lack of things. So on the left is shadowing, that's more likely to be grade 1, and on the right is enhanced through transmission, that's more likely to be grade 3. Now when we look at molecular subtypes, this is important for treatment because you can't treat all cancers the same way, and certain subtypes respond to different types of treatment. And so that's where this all became very important. Now, again, molecular subtypes tend to be best defined by genetic assays, but we've come up with surrogates for molecular subtypes using ER/PR, HER2, and Ki67. So luminal A is the most common. It's about 50% of all cancers. It's ER and or PR positive and HER2 negative with a Ki67 of less than 13. Luminal B is ER and or PR positive and HER2 negative, but Ki67 greater than 13, or ER and PR positive but HER2 positive. So about a certain percentage, about 30% of luminal Bs are HER2 positive. HER2 positive is ER and PR negative but HER2 positive. And that's defined as either a IHC 3+ or an IHC 2+ with an amplified FISH. And then triple negative, all three are negative, ER, PR, and HER2. Now, again, luminal A is the most common subtype. They're thought to arise from luminal epithelial cells of the acinus, and therefore they're AABs, acinar adenocarcinomas of the breast. They tend to be unifocal about 3/4 of the time. ER is very positive. The Ki67 is low. They respond to tamoxifen and aromatase inhibitors. They have the best overall survival of 80% at 5 years, with, unfortunately, continued risk after 10 years, more than other subtypes. When they metastasize, they tend to metastasize to bone. And a typical path report for a luminal A would be a grade 1, irregular shape, spiculated, ER positive, 100%, PR 100%, HER2 negative, and a Ki67 of 5. Luminal B is about 15% of all breast cancers. They're also thought to arise from luminal epithelial cells, and therefore also AABs, acinar adenocarcinomas of the breast. They're more commonly multifocal than luminal A's, and up to 53%. The ER is usually more weakly positive, the PR more weakly positive. The Ki67 is 14 or greater. They have a higher p53 mutation rate, a lower survival, about 40%, 50 years, but again, metastases tend to occur to bone. So these are more typically grade 2 to 3, irregular in shape, indistinct margins. ER might be 30, PR might be 10, HER2 might be 1+, and Ki67 might be 25. The HER2 subtype is again about 15% of all cancers. They're thought to arise from luminal epithelial cells of the duct, not of the acini of the TDLU, and therefore they can be DABs, ductal adenocarcinoma of the breast, and some of them might be called grade 3 DICIS. They're multifocal in almost 2/3. They've got a higher positive percentage of lymph nodes. They tend to have a high Ki67, about a 3/4 p53 gene mutation rate. They tend to have higher DCIS components with fine linear calcifications. They can have 31% survival at 5 years, and the metastases tend to be more visceral and brain, liver, lung, less likely bone, so they're typically grade 2 or 3 with irregular shape and indistinct margins often have nuclear grade 3 DCIS with commuter necrosis and casting calx, ER negative, PR negative, HER2 3 plus or 2 plus with a amplified FISH, and a Ki67 often pretty high, say 50 or 60%. Triple negatives, again, about 15% of all breast cancers. They're thought to arise from myoepithelial or basal cells of the acinus, and therefore they're AABs. They're usually unifocal, more common in BRCA1 mutation and more common in African Americans. They have a 80% P3 gene mutation rate, low rate of lymph node metastasis. Strangely enough, they tend to spread hematogenously more early, and they're less associated with DCIS and DAB. High recurrence rate at 1 to 4 years, but if you can make it to 5 years, you may have survived them. Again, their tendency is toward visceral brain mets. So typically they're going to be grade 3, irregular shape, indistinct margins, ER negative, PR negative, HER2 negative, and pretty Ki67. So sound transmission does tend to be a prognostic indicator for molecular subtype. It can distinguish triple negative from other molecular subtypes with a p-value of 10 to the minus 13, distinguishes luminal A from other molecular subtypes with a p-value of 10 to the minus 14, and even distinguishes HER2 from other molecular subtypes with a p-value of 0.003. Here we're showing the complete or partial enhancement versus molecular subtype, and we can see that partial or complete enhancement goes with triple negative. It indicates a 5.5 times likelier that it's triple negative than luminal A. And complete or partial shadowing makes it 6.8 times more likely to be luminal A than triple negative. So enhanced through transmission tends to go with triple negative. Luminal A tends to go with shadowing. So on the left, we have enhanced through transmission. That's going to be more likely to be a triple negative subgroup. And we have pretty strong shadowing on the right. That's going to be more likely luminal A. Now, the sound transmission is somewhat confounded by histologic grade, and so we can see our plot of our own data, 524 invasive breast cancers. Most luminal A's are grade 1 or grade 2 with very few grade 3s. Most luminal B's are grade 2 or 3 with fewer grade 1s, and essentially no grade 1s among the HER2 or triple negative subgroups. And so there's an intercorrelation between histologic grade, molecular subtype, and sound transmission. So here you're seeing complete or partial enhancement versus grade, and sound transmission versus molecular subtype, and then we can see grade versus triple negative, and so again, we can see the most triple negatives are grade 3 with about a quarter being grade 2 and essentially none being grade 1. But it's not. There's some intercorrelation there, and again, the opposite is true here, where a grade 1 tends to go with shadowing, luminal A tends to go with shadowing, but most grade 1s or most luminal A's are going to be grade 1 or grade 2, with very, very few being grade 3. So if we look at the sound transmission scores again, the sound transmission score goes up with the degree of shadowing, and we can see the triple negatives and HER2s tend to have less shadowing in luminal A or luminal B, and luminal A has more than luminal B. So again, we've got shadowing on the left, enhanced through transmission on the right. Shadowing is more likely to be luminal A grade 1, and enhanced sound transmission is more likely to be triple negative and grade 3. What about orientation, say taller than wide? We know that AABs arise from the acini. We know that the acini are more typically distributed around the periphery of the mammary zone. And we know that anterior and posterior TDLU tend to be vertically oriented. So if a cancer arises from a TDLU and it stays within the TDLU, it's going to tend to reflect the orientation of the TDLU. So about 70% of luminal A's are going to be taller than wide. The DABs arise in the ducts, which are in the center of the mammary zone, were horizontally oriented, so they're going to very rarely be taller than wide. So we expect a very low percentage of taller than wide in DABs, or so-called DCIS or HER2 group, whereas luminal A's are more likely to be taller than wide. So these are small single TDLU cancers, a posterior AAB, an anterior AAB, a terminal AAB. And we can see that the likelihood of a lesion being taller than wide rapidly falls off with increasing size. So this is primarily a feature of small cancers, which is typical also of luminal A's. So indeed, grade 3 invasive breast cancers do have a lower percentage of non-parallel orientation than grade 1 or 2. In other words, grade 3 is less likely to be taller than wide than grade 1 or 2. And triple negatives tend to have a lower percentage of non-parallel orientation than luminal A or B. So when we look at this non-parallel orientation, the probability of it being grade 1 is much higher when it's taller than wide. And the probability of it being taller than wide is lowest for HER2. Why? Because HER2, we think, arises from the epithelial cells of the duct. The ducts are horizontally oriented, not vertically oriented. So it makes sense that we would get a lower percentage of non-parallel orientation in the HER2 subgroup. So this is a small single anterior TDLU cancer. That would be typical for luminal A. And this is an extensive multifocal disease, much wider than tall, which is typical for HER2. Now, what about enlargement of ducts in the surrounding tissue? Well, we know that if there's enlarged ducts, there's more likely to be a large DAB component. And we know that luminal B and HER2 subgroups or subtypes are the most likely to have extensive DCIS components. And we know that there are 4 components that contribute to the enlargement of ducts. That's tumor cells within the lumen, necrosis or secretions within the lumen, periductal lymphocytic reaction, periductal desmoplasia. And 3 and 4 really tend to only occur in grade 2 and grade 3. So here we're showing a normal duct on the right side, shown on the left screen, and a grossly enlarged duct on the left side of the breast, of the left breast, which is shown on the right split screen. And at the widest point of the duct, we can see there are all 4 components contributing. We've got the pink tumor cells within the lumen, this micropapillary DAB. We've got clear secretions within the lumen. We got pink periductal desmoplasia. We got purple periductal lymphocytic reaction. But at this yellow double-headed arrow is exactly where we've taken this vacuum device, and where the duct is widest, all 4 of those things are contributing. Also notice that we have microlobulation up within the yellow circle, and each of the microlobules tends to be a duct filled with micropapillary DAB. So we know that nuclear grade 3 can enlarge the duct grossly compared to normal ducts. It can be 4, 6, 8, 10 times normal size. Grade 2 causes a more minimal enlargement because there's less often periductal lymphocytic or desmoplastic components, and the ducts might be 2 to 4 times normal, but if there's any duct ectasia, it could be difficult to tell a duct 2 times normal from a normal duct. And grade 1 frequently does not enlarge the duct enough to be able to distinguish them from normal ducts. So these are grossly enlarged ducts. That tends to go with grade 3. These are medium-sized enlarged ducts in the surrounding tissue. That tends to go with grade 2. And the really thin ones that just look like slightly thickened spiculations may actually go with grade 1. Same with microlobulation size. Big, gross microlobulations tend to go with grade 3. Little bitty teeny ones with grade 1, and intermediate-sized ones with grade 2. So when we look at the significance of enlarged ducts in the surrounding tissues, what we can see is that we can distinguish grade 3 from other grades with a p-value of less than 10 to the minus 7th. Grade 1 from other grades, p-value 0.001. Luminal A from other subtypes, p-value 0.000006. And triple negative from other subtypes with a p-value 0.000007. Now we can see that HER2 is about twice as likely when there are large ducts in the surrounding tissue, and that can be a HER2 positive subtype, or it can be a luminal B with HER2 positivity. Both of those tend to have significantly larger DCIS components. And again, when we look at enlarged ducts, it's going to be more common with grade 3 than with grade 2 or with grade 1, largely because we can't necessarily appreciate or distinguish grade 1 from normal ducts. But notice when we look at the molecular subtypes, it's definitely more likely that we're going to see enlarged ducts in the surrounding tissue with luminal B or HER2 molecular subtypes with, 2.3 to 2.9 times increased likelihood of HER2 positivity. So here's examples of markedly prominent ducts in the surrounding tissue. On the left is multifocal with extensive DA-Khabib components, and on the right is a single focus with enlarged ducts in the surrounding tissue. The left is a luminal B, the right is a HER2. These are extensive linear branching calcifications on the mammogram. These are very typical of HER2 positivity. Again, it can be either the pure HER2 positive molecular subtype, or it can be luminal B with HER2 positivity. Either one of those can give rise to that. Now, what about the relative thickness of the echogenic rim compared to the size of the hypocoexcentral nidus? And so on the left is a typical luminal A, where we've got a very narrow hypocoexcentral nidus, a relatively thick echogenic halo, and very long, prominent peripheral zone spicules. We do have a thick echogenic rim in the triple negative on the right, but if we take a ratio of the echogenic rim to the hypocoexcentral nidus, it's only slightly over 1, whereas if we look at the echogenic rim ratio to the hypocoexcentral nidus ratio, it might be more than 2 to 1 on that small luminal A on the left. So relatively thicker echogenic rim in luminal A than triple negative, and relatively longer spicules compared to the hypocoexcentral nidus in luminal A than triple negative. And so when we plot this out, if we look at boundary zone, that gives us a measurement of the thickness of the echogenic rim. So the thicker the echogenic rim, the higher the boundary zone score. So you can see the grade 1 has, a more prominent echogenic rim than grade 2, which has a more prominent echogenic rim than grade 3. And that there's almost no overlap between grade 1 and grade 3. We look at molecular subtypes again versus the echogenic rim. Again, we can see that higher for luminal A, less prominent for triple negative. Now, if we look at spicules, again, the length and prominence of the spicules is going to lead to a higher peripheral zone score for grade 1 than grade 2, and higher grade 2 than grade 3, because spicules are going to be less prominent in grade 3, and by the same token, they're going to be less prominent in triple negative. So we can see much lower peripheral zone scores, meaning less spiculation for triple negative than for luminal A or luminal B. And again, these p-values are color-coded so that green means a p-value less than 0.001. Now, what's interesting, I've had pathologists tell me there is no such thing as grade 2. They were just joking. But they said, there's really only grade 1 and grade 3, and when I can't tell the difference between the two, I call it grade 2. Well, in fact, they were kidding less than I thought. And what we've noticed, no matter what parameter we look at, whether it's sound transmission, length of spicules, thickness of the echogenic rim, we see a big difference between grade 2 and grade 3, and only a small difference between grade 1 and grade 2. Now, why is that? Well, what I'm showing here is a PAM60, and it's a genetic assay. And what they found is that there's grade 1, and there's grade 3, and then grade 2 is divided into 2 subcomponents, a grade 1 like grade 2, and a grade 3 like grade 2, and about 2/3 of the grade 2s are actually grade 1-like, and only 1/3 are grade 3-like. So that explains genetically why grade 1 and grade 2 are more difficult to distinguish from each other than it is to tell grade 2 from grade 3. Now this gets to be very complicated, and all I want to show you is when we compare different grades, remember green means less, the p-value is less than 0.001, and aqua means better than 0.05. We can see that there's lots of green telling grade 1 from grade 3. There's lots of green telling 2 from grade 3, but not much, it's much closer between grade 1 and grade 2, which is, again, what I just showed you in the reflection of genetics. Now, when we look again at comparing molecular subtypes, we see lots of green and telling luminal A from all the others, and lots of green and telling triple negative from all the others, but less significant differences between luminal B and all those, and HER2 and all others. So if we look at specific molecular subtypes, again, we can see our best ability is to tell luminal A from triple negative, but we also have pretty good ability to tell luminal A from luminal B, luminal A from HER2, luminal B versus triple negative. Much less effectiveness triple negative versus HER2 or luminal B versus HER2. Now, what this shows is that if I take 5 ultrasound categories, ultrasound feature categories: shape, internal echo pattern, sound transmission, which is posterior features, margin, which is no longer in BI-RADS 5th edition, but we still use, and surrounding tissue, you can see that the most common or most typical answer differs in 4 of the 5 categories between luminal A and triple negative. But unfortunately, we're not dealing with 0% for one and 100% for the other. We're dealing with 51% versus 32%, 30% versus 26, 43 versus 52. This is difficult for the human mind to deal with because we like concordances, and these minor differences are really hard to pick up. And this is where I think machine learning comes in, because it can help sort through these. Now, you can also look at minor features. And so we can see that if it's oval shaped, it's 18 to 1 times more likely to be triple negative than luminal A. But is it a majority of cases? No, it's 9% of cases. So when we see it, it's helpful. It pushes us towards triple negative. But in the majority of cases, we're not going to see it. If we look at complex cystic and solid, again, we're looking at a 27 to 1 ratio, making triple negative more likely. But what percentage of the cases do we see it in? 14%. So 84% of the time, that's not going to help us. So in all these cases where I'm showing these pink ratios, you can see they're all better than 4 to 1. So when they're present, they're helpful, but when they're not present, they're not helpful. And so again, I think this is where the human mind has difficulty dealing with this information overload, and that you need machine learning to help sort through all this complexity of data. So here's a small, taller than wide, densely shadowing lesion with angular margins, thick echogenic rim, and some peripheral zone spiculations. So, these are the scores. Thin spiculations is a 4. Boundary zone spicules is a 6. Irregular with angles is a 5. Severely hypoechoic is a 5. Complete shadowing is a 5. And so these are all findings that are very typical of luminal A. This, on the other hand, is, some people might call this oval. It's really irregular, but it's got enhanced through transmission. Doesn't have a very thick echogenic rim. It's got a few non-prominent spiculations. It's going to have lower scores in the peripheral zone. This is really quite typical of a triple negative. So what we want to do is find some way of putting together this myriad of differences in prognostic biomarkers for shape, echo pattern, posterior features, boundary zone, peripheral zone. And we want to be able to feed them into a black box machine learning thing and come out with a likelihood for various prognostic biomarkers like ERPR, HER2, Ki67, and molecular subtype. And so how this could be output is saying that the mean likelihood of a lumen is 92% with a 95% confidence interval from 80 to 96, blah, blah, blah. Or it could put out graphically in the sort of a manner where, if it were lumen, it'd be, you'd see a mean and 90% confidence interval off to the right, with it being less likely to be luminal B, HER2 or triple negative based on the features we're seeing here. And for a triple negative, it'd be the opposite. It'd give you a higher likelihood of a triple negative and less likelihood of a luminal A. Now, is this doable? It is. Am I overly optimistic? Almost certainly overly optimistic in the width of the confidence intervals. They're probably going to be wider and perhaps even more eccentric. But I think it's very much doable. So this is how I envision it going. You'd have some sort of graphical interface. You'd click on the image that corresponds to the score. So that'd be thin peripheral zone spicules. That'd be a 4. Thick echogenic rim would be a 5. Irregular with angles would be a 5. Markedly hypoechoic would be a 5. And shadowing would be a 5. And so you'd plug all those things in, and this is what you'd get. You get a likelihood of ER positivity, PR positivity, low Ki67, low positive likelihood of HER2, and that it would predict that it's most likely luminal A. And I think you could even get a likelihood of lymph node status based on the combination of other features. Now, what we've shown is that this is radiogenomics, this is machine learning. In radiogenomics, the radiologist is still identifying and scoring the features with his eyes and brain, his or her eyes and brain. And then the computer is just fitting all the data together to come out with various predictive likelihoods of individual biomarkers and molecular subtypes. Radiomics would be the next step. That would involve auto-segmenting the lesion into zones and then auto-scoring some of the features we already use or perhaps new features that the radiomics could find. So this is a case where you might have the AI deep learning, auto-segment, auto-score, and then do all this. So what the deep learning would give you is more efficiency and perhaps even better performance if it's able to see things that radiologists don't see well. And what I just showed you was graphic interfaces, but obviously you can have structured reporting interfaces. Radiologists tend to be visual learners. They might like to see graphic interface, but surgeons and medical oncologists might much prefer to see structured reporting like this, where it would tell you what all the scores are and just give you a numeric likelihood of ER positivity, PR positivity, and all that. Now, do I ever believe that the imaging biomarkers are going to completely replace the need for histologic biomarkers? And I'm not saying that at all. But what we do know is that about 20% of the time, if you do biomarkers on the core biopsy and you do biomarkers on the surgical specimen, and the patient has not undergone any treatment in between the two, about 20% of the time, we get different biomarkers and different molecular subtype, which means about 20% of the time, the patient could get a less than optimal treatment. Now, it is because of this, and why does this happen? Internal heterogeneity. Remember that when we do histology, whether we do core biopsy or surgical biopsy, only a tiny percentage of the lesion is actually being evaluated, and the biomarkers that we get are going to depend on randomly where we obtain those within the lesion. So it's recommended, because of this, that the biomarkers always be repeated on the surgical specimen before the patient undergoes definitive treatment. I can tell you from our 16 centers in the United States and our 3 centimeters in the Netherlands, virtually no sites were repeating them. They were mostly getting them on the core biopsy, not repeating them on the surgical. And so the way I view these being used is when you look at your primary histologic result, benign versus malignant, your secondary histologic result, invasive versus non-invasive, etc. You want to do a concordance-discordance assessment between imaging of the features. But I think it's also possible to do a concordance-discordance assessment for prognostic biomarkers. And so what I'm saying is that if a site is refusing to repeat the biomarkers on the surgical specimen, and why do they do this? Because insurance usually only pays once, and so it's hard to get insurance to pay for it. But if you have discordance between the imaging biomarkers and the core biopsy biomarkers, it might tell you that, hey, we might be treating the patient less than optimally if we go on the core biopsy thing. If you get a discordance in the predictive imaging biomarkers and the core biopsy biomarkers, it might tell you for sure that you actually need to go repeat the biomarkers on the surgical specimen. So again, I don't think we're going to be replacing histologic biomarkers, but I do think that the prognostic biomarkers could be an important concordance-discordance assessment, as I just described. Thank you.